Hello and welcome to the Surgeon's Barroom. In this video, we shall discuss about pilonidal sinus. Now, the term pilonidal sinus, it describes a condition found in the natal cleft overlying the coccyx, which consists of one or more, usually non-infected, midline openings. These midline openings communicate with a fibrous tract lined by granulation tissue and contains hair which lies loosely within the lumen. Now, let us break this definition into parts to understand it. Let us simplify it. It is found in the natal cleft. The natal cleft is the area between the two gluteal regions. That is, it is the area between the butt cheeks, which it overlies the coccyx. It consists of one or more, usually non-infected. Usually is the key term here. So it is usually non-infected, but it can become infected. In which condition it forms an abscess. It consists of one or more, usually non-infected midline openings, and these midline openings they communicate with a fibrous tract lined by granulation tissue. This fibrous tract lined by granulation tissue is nothing but the definition of a sinus. And this pilonidal sinus, it contains hair which lies loosely within the lumen. So you need to pay attention to these words over here. It does not contain hair follicles. It contains hair which lies loosely within the lumen. Now let us look at this image from Sabiston to understand the definition of a pilonidal sinus. Now, first I had told it is a condition which is found in the natal cleft. This area is the natal cleft. That is, it is the area between the butt cheeks. That is, between the two gluteal regions. This, it overlies the coccyx. That is, it overlies the coccygeal part of the vertebrae. It consists of one or more, usually non-infected midline openings. So you can see one opening over here. You can see one more big opening over here. Smaller openings over here. So these openings are present in the midline. These are infected and they communicate with an opening in the laterally. So midline openings are usually present and this lateral opening may or may not be present. And this entire tract, so the tract which connects these various openings and this opening to the lateral opening, this tract is lined by granulation tissue. So you can see over here, this red tissue over here, this is granulation tissue. This granulation tissue, it lines the tract which connects this opening to these midlines. That is, it lines this tract. It also lines this tract. And if you cut open this, supposing if you excise this pilonidal sinus and then you lay it open, then you can see hair which lies loosely within it. Now let us discuss the etiology. Now earlier it was thought to be congenital, but the congenital theory is now considered to be obsolete. So nowadays the recent thinking is that it is an acquired disease. So now why do we say it is an acquired disease? This is because of the following reasons. Firstly, now pilonidal sinus can also occur in between the digits. So supposing this is the hand, it can also occur over here in between the digits. So interdigital pilonidal sinus is an occupational disease which is present in hairdressers, that it is present in barbers. So now supposing, say, if it were not to be an acquired disease, if it were to be a congenital disease, it would not show an occupational predisposition. The very fact that it shows up an occupational predisposition suggests that it is an acquired disease. Now a pilonidal sinus in the gluteal cleft is more commonly seen in jeep drivers or truck drivers. So there too you are seeing an occupational cause. Second, the age of appearance. Now the age of appearance is older than that which is expected to be of a congenital lesion. That is to say, if it were a congenital lesion, it would have presented earlier. Then hair follicles are rarely present in the walls of the sinus. Now pay attention to these words carefully. Hair follicles are rarely present. So going back to the definition, it says it contains hair lying loosely. So note that there are no hair follicles mentioned in the definition. Likewise, hair follicles are rarely present in the walls of the sinus. It contains hair loosely. If it were to be a congenital disease, then you would see hair follicles within it. Then pointed hair ends are directed towards the blind end of the sinus. That is to say, in this diagram, now let us imagine that this is a hair follicle. So this is a hair follicle. This is the root of the follicle. Alright. So this pointed end of the hair follicle, that is to say this portion, this is what they are talking about over here. The pointed hair ends are directed towards the blind end of the sinus, that is they face inwards. If it were a congenital disorder, it would be facing outwards. It mostly affects hirsute men, that is, it affects men who are more hairy. So this itself indicates it is an acquired disease. And lastly, recurrence is common even though adequate excision of the tract is carried out. That is to say, because certain individuals are predisposed to it. Okay, now let us discuss the pathogenesis. Now, shed or broken hair collects in the natal cleft. That is, whatever hair is present, say let us say in the back or the hair within the gluteal cleft, whatever hair is shed or whatever hair gets broken, that collects in the natal cleft. Now there is buttock friction, that is between the butt cheeks there is some friction, maybe during sitting, for example seen in jeep drivers. They are sitting the whole day, so there is considerable buttock friction. This combines with shearing forces. Now because of these factors, that is the buttock friction and shearing forces, the hair is drilled through the midline skin. Also, it predisposes to it. Also, there is infection in relation to a hair follicle. This allows hair to enter the skin by suction. So, two things. Firstly, the buttock friction and shearing forces, it drills the hair through the midline skin. Secondly, if there is any infection which is related to the hair follicle, that allows the hair to enter the skin. Now, this is because of suction, which in turn is because of the buttock friction and shearing forces. Now, because of these factors, there is a subcutaneous, chronically infected midline tract, that is a primary pilonidal sinus. Now, secondary tracts may spread laterally, which may emerge at the skin as granulation tissue lined discharging openings. So, let us look at this diagram again. This is the primary tract that we were talking about earlier. So, this is the primary tract. Let me use a brighter color. This is the primary tract. And secondary tracts spread laterally. They emerge in the skin as granulation tissue lined. So, you can see this red tissue over here. So, they emerge in the skin at the skin as granulation tissue lined discharging openings. So, this opening, it may discharge. If it is infected, there might be purulent discharge. So, secondary tracts may spread laterally, which emerge at the skin as granulation tissue lined discharging openings. Now, the sinus tract runs cephalad. That is, the sinus tract, it always runs in this direction. It never runs in this direction. So, in this patient, presumably this was the first opening, and this is the direction of the sinus tract. So, it always runs in this direction. It never goes in a caudal direction. This is not seen, these are seen. Also, now since this is a chronic condition, you might wonder whether there is carcinomatous changes. So, carcinoma arising in chronic pilonidal sinus is very rare. Now, what are the clinical features? Now, they are more common in men than women. They are more common in the age group between puberty to 30 years, because that is when hair development occurs, and that is when it is also seen in certain occupations who are predisposed to these conditions, for example jeep drivers. So, it is in this age group that a person is most active in that occupation. It is more common in dark haired people, than people who have soft blonde hair, because see, this says soft blonde hair. Now, dark hair which is coarse, is more predisposed to pilonidal sinus more than soft hair. Now, these patients complain of intermittent pain, swelling, and discharge at the natal cleft. The patient will also give you a history of repeated abscess formation that have either burst spontaneously, or maybe he has visited doctors in the past, and those doctors have incised and drained those abscesses. Now, the primary sinus may have one or more openings, all of which are strictly in the midline. This is the keyword. These are never present laterally. The primary sinus is always present in the midline. The secondary sinuses may go in a lateral direction, but the primary sinus is always in the midline. It is between the level of the sacrococcygeal joint and the tip of the coccyx. So, when you look at the vertebral structure, it is between the sacrococcygeal joint and the tip of the coccyx. So, I mean, this is the sacrum, and this is the coccyx. This is how it looks like. So, it is always present between it always present in the skin which overlies this region, that is between the sacrococcygeal joint and the tip of the coccyx. Now, the differential diagnoses include hidradenitis suppurativa, a complex anal fistula, osteomyelitis with draining skin sinuses, and infective conditions such as TB and actinomycosis. Now, how do you treat a pilonidal sinus? Now, the treatment is difficult because it tends to recur. Now, supposing if a patient presents to you with an acute exacerbation. Now, during an acute exacerbation, you cannot obviously excise the sinus, you just have to drain it. So, an abscess should be drained through a small longitudinal incision which is made over the abscess and away from the midline. So, let us look at this again. Now, supposing in this patient has an abscess. It is in the abscess is, let us say, the abscess is in the midline. So, this is the region of the abscess. The incision should be made longitudinally. It should be made away from the midline. So, you make it somewhere over here. You should never make the incision in the midline. So, the incision is made away from the midline, and once you make the incision, you then curate it, that is, you clean it, you remove all the granulation tissue and hair that has collected. Now, supposing a patient comes with chronic pilonidal sinus, then what do you do? So, there are certain procedures which can be done. First, this is the easiest option. You lay open all the tracts, and you may or you may not do a marsupialization. Second, you excise all the tracts plus or minus primary closure. So, after excising it, you can either leave it to heal by secondary intention, or you can close it primarily. Now, if you close it in the midline, so now this is the gluteal cleft. Let me draw a nice diagram. Now, supposing if you close it in the midline, then obviously there is tension over here, and because of the tension, it tends to recur. So, if you want to prevent recurrence, you then do the third method. The third method is excision of all the tracts plus closure by a mean which avoids a midline wound. That is, you ensure that there is a tension-free closure. If there is no tension, then there is lesser chance of it recurring. So, now how do you do that? One option is a Limburg flap. So, in a Limburg flap, you do a rhomboid excision and then you close that excision via a rotational flap. So, this was a case that I had operated on a few days ago. Now, this is the rhomboid excision. Alright. So, this part has been excised, and once you excise that part, you take a rotational flap. So this goes over here. Next, you can do something called a Z plasty. Then you can do something called the other option is something called a Caryducus flap. Now, a Caryducus flap is, as the name indicates, it is an off midline excision, not as the name suggests. I meant as we're discussing in this, all the flaps entail closure which is away from the midline. So, in a Caryducus flap, you do an off midline excision and then you close it via an advancement flap. So, you may have noticed by now that after excising the parietal sinus, we're all trying to, in all the methods, we're trying to bridge the gap via a flap. So, if it was a rotational flap, it is called a Limburg flap. If it is an advancement flap, then it is a Caryducus flap. So, as you can see in this diagram over here, see these openings, this is the parietal sinus, this dotted line, this indicates the site of the incision. So, this is a view from on top and this is a cut section. So, this is a parietal sinus, this is the cut section, this is a view from top. This is a view from the top and this is a cut section. So, you make an incision, here you made the incision, you have excised that. So, you can see the gap over here. Now, this gap is closed via this flap. So, this is called a Caryducus flap. Now, as you can see in the final result, this is the line of suture. This line of suture, which corresponds to this portion in the cut section, this is away from the midline. Because it is away from the midline, there is tension free closure. Now, this diagram is from the latest edition of Bailey, that is the 28th edition of Bailey. So, here you can see that you've made this is the Caryducus flap. You've made this red tissue, it represents the excised area, and skin from this portion is brought over here. I mean, tissue from this portion is brought over here and sutured. This is a Limburg flap. This is a Limburg flap. Okay. Next, we have something called a Bascoms procedure. Now, in a Bascoms procedure, it consists of the following. You first make an incision lateral to the midline. You make an incision lateral to the midline. This gives you access to the sinus cavity. Now, once you gain access to the sinus cavity, you remove the hair and the granulation tissue. After you've removed the hair and the granulation tissue, you excise the sinus and you close the midline pits. Once you've closed the midline pits, the lateral wound is the site of entry via which you have gained access to the sinus. The lateral wound is left open to heal by secondary intention. Now, let us look at this diagram. This is taken from the latest edition of Bailey and Love. So, this is the, which color do I use? This is the opening of the sinus. Alright. So, you make an incision laterally. After you made an incision laterally, you can gain access to the sinus cavity. Once you've gained access to the sinus cavity, as you can see over here, this is a gauze piece which is being pushed into the sinus via an artery forceps. So, this gauze piece, it curettes, that is, it removes all the hair and the granulation tissue. Then this portion is excised. So, this portion over here, you make a diamond shaped incision and you excise this. So, once you excise this, this is taken care of, and then this portion heals by secondary intention. So, let us look at Bascom's procedure. Sounds a bit complicated. So, let us look at it again. You first make an incision lateral to the midline to gain access to the sinus cavity. Once you gain access, you remove the hair and the granulation tissue. Then you excise and you close the midline pit. After you've excised and closed the midline pit, you let the lateral wound be open to heal by secondary intention. Now, after you've done any procedure, you have to ensure that in the post-op period, adequate wound care is given, and that the patient undergoes some form of hair removal. That hair removal can either be by regular shaving, or it can be via lasers, or it can be via depilation by trimming, whatever the means. But the patient needs to undergo post-op elimination of hair. Now, to recap the treatment, if you are a UG student, that is, if you are preparing for MBBS exams, at least remember these names. So, first was a Limburg flap, second is a Cariadakis flap, there is also a Z plasty, and there is a Bascom procedure. So, if you can remember these names, at least the names, then that would be enough. I hope you found this video useful. Thank you.